be a precursor of CSC, or it can be an outcome of resolved CSC, and it can evolve into further pachychoroid neovasculopathy or PCV. So in this case, you see that in the first picture, you see that there is pachy vessels, and although there is no presence of SRF, there is only RP changes. But further, it can lead to there is presence of subretinal fluid, and it can be a precursor of CSCR. In this picture, you see there is presence of RP changes, pachy vessel, subretinal fluid, and later you see that the subretinal fluid gets resolved, and only the RP changes and pachy vessels are seen. So PP can be when the SRF gets resolved, it can look like PP also. In CSCR, there is diffuse or focal pachychoroid features along with serous PEDs, and SRF appearing is ill-defined circular ovum dome-shaped elevation of neurosensory retina, and it occurs when the RP pump mechanism gets overwhelmed by increased choroidal permeability. So CSCR, again, it is serous detachment of neurosensory retina. It can be acute or chronic, and it is often associated with one or more serous PEDs. So when do you suspect CNVM in a case of CSCR? When there is presence of persistent subretinal fluid, there is presence of pachy vessels, increased choroidal thickness, there is compression of choriocapillaries, loss of RP layer, and double layer sign. So what is basically double layer sign? So you see that if it is hyperreflective DLS, so it is a indication of there can be neovascularization. If it is only hyporeflective DLS, it can be seen in CSCR only. In pachychoroid neovasculopathy, again there is all the pachychoroid features associated with RPE alterations and subretinal fluid, and there is associated type 1 neovascularization and hyperreflective double layer sign is there. So this is the pachy vessels. You can see overlying the there's double layer sign, there is presence of subretinal fluid. Again in this picture you see that there is presence of subretinal fluid, there is hyperreflective double layer sign, and although there is no neovascularization is seen in this picture, although in this octa you see there is presence of neovascularization, so it can be pachychoroid neovasculopathy. So how do you differentiate pachychoroid neovasculopathy from neovascular AMD? It is usually present in younger age group. There is no associated drusense, no or minimal exudation, no or minimal hemorrhage. All the pachychoroid features are there, and it is usually slower involving. Coming on to PCV, it is primarily a disease of choroid, and it is associated with serous exudation and hemorrhage that may lead to detachment of RP and sometimes neurosensory retina. So it can be of exudative type, hemorrhagic type, or mixed type. So definitive diagnosis is by ICG. You see multifocal choroidal hyperfluorescence, polypoidal vascular dilation, and presence of branching vascular network. So on OCT, how do you diagnose the PCV features? In this picture you see there is multilobulated or notch PED in the left picture. In the middle picture you see there is sharp peak PED where the angle is 70 to 90 degree. And in the third picture you see that there is hyperreflective ring underneath the PED. So again, this is sharp peak PED, this is thumb-like PED, and here you see that there is a presence of hyperreflective ring along with hyporeflective lumen, which is indicative of polyp on OCT. So this is a picture, you see that multilobulate PED is there, and status post anti-VEGF, although the PED has resolved, there is still presence of BVN on octa. So there is another term called focal choroidal excavation. It is a structural abnormality with unknown etiology consistent with localized concavity in the choroid occurring without posterior staphyloma, and it can be associated with type 1 or type 2 CNVM. In peripapillary pachychoroid syndrome, there is usually presence of characteristic abnormality same as pachychoroid spectrum is there. The nasal choroidal thickness is more than temporal choroidal thickness, and the nasal IRF or SRF is there, and occasional disc edema. So to conclude, pachychoroid is spectrum of disease which needs to be recognized early and at correct stage. In patients with CSCR with persistent SRF, you should suspect of CNVM. Multimodal imaging is helpful in this, like enhanced depth imaging, OCT, octa, and ICG, and understanding the mimickers and OCT biomarkers is necessary. Thank you.
I think very good presentation, covered almost all aspects, which is difficult. I think there could be a lot of discussion. Maybe we can have, if there is any. Yeah.
I wanted to ask the panel, so what is the application of pachychoroid disease in the real world? I mean, how do we treat this patient differently and how do we counsel such patients differently from a normal choroid?
I think more from whatever we learn at this time and whatever we have understood, most of the time you will not be treating, because I think it is like, as she mentioned, it is whole spectrum and we go through the various stages. Even pachychoroid neovasculopathy, you may not treat it, but you observe it. So that's where I think the biggest confusion, at least I have had, and I have asked many people, is about this double layer sign, because this is present in everything, everywhere. And the situation is more complicated once you have already given multiple injections. It will persist. So I think what we, at least I have learned, no, don't concentrate on that. Don't try to kind of collapse that. Let it be until unless there is a fluid. So I think it creates many a time situation for us. That is something which I thought I would mention.
Other thing, I think Octa sometimes will be helpful. I don't know how many of us has access to ICGA, but
Yeah,
Octa
I
is
think
becoming a little more
the problem
frequent.
is most of the time you may not pick all the time these polyps. That's a problem. You may also pick up VVN, but then the question is we are not treating these. Now there is a question that, and we have enough data, many studies, that even if you are observing all these, even if there is a frank neovascularization and there's no leakage, you're just observing it. So that part is clear at this time. At least that part is not something which should be confusing. So is all these tall, big PEDs, it may be huge. Now there's a big study where we may do more harm and it may rupture and you may create more issues until unless it has really gone into that stage which is start leaking. Even that fluid on the top is not. It is not because it's because the photoreceptor are getting there. So I think many things we have to learn. So that is what is happening. Thank you. I think we'll, yes. Okay, you're the next. Oh, great.
She's not Shilpa.
After such a beautiful talk, it's a very basic talk. So I'll be talking on branch retinal vein occlusion and its management. Learning objectives, mainly to diagnose and how to manage. So this was first described by Theodor von Leber in 1877. So this branch vein occlusion refers to the obstruction of a branch of the retinal vein at arteriovenous crossing. The compression of the vein is thought to cause endothelial cell loss, turbulent blood flow, which leads to thrombus formation. It is the second most common retinal vascular pathology after diabetic retinopathy, most commonly seen in superotemporal quadrant and also in inferotemporal retina. Nasal involvement is rare and usually is asymptomatic till neovascularization causes a vitreous hemorrhage. So this is the classification. Major and macular. In major, it is major at the disc, away from the disc, and peripheral. Macular when it involves the macular bundle. So these are the few pictures. The main risk factors are age, increasing age, hypertension, hyperlipidemia, diabetes, glaucoma or ocular hypertension, oral contraceptives, smoking, increased BMI at 20 years of age is also contributing to a risk factor. The uncommon risk factors are dehydration, myeloproliferative disorders such as myeloma, polycythemia vera, thrombophilias, wherever there is increased hyperviscosity of the blood, hyperhomocystinemia, inflammation which can cause occlusive periphlebitis. Other risk factors are Behçet's sarcoidosis, Wegener's granulomatosis, orbital diseases, chronic linear failure. Even in retinal diseases such as Eales disease, toxoplasmosis, Coats disease, it is also seen. So the diagnosis is mainly when the patient complains of the symptoms, and the symptoms depend on the location of the vein occlusion. So if it is far away in the periphery, patient might not describe that he is having any problems. But if it's involving the macular region, it is a painless blurred vision, often accompanied by metamorphopsia, and iris neovascularization and neovascular glaucoma are also seen in 2 to 3% cases at 3 years. So the fundus picture is typical, and the diagnosis is mainly on seeing on fundus. So dilatation and tortuosity of the affected venous segments will be there. Flame-shaped hemorrhages may be there, also dot blot hemorrhages, few cotton wool spots, and retinal edema can be present. More commonly in the superior branch vein occlusions, where the fluid descends to the macula. After the acute phase, it resolves in 6 to 12 months. The vessels may have sheathing and sclerosis and might lead to persistent and recurrent hemorrhage. Neovascularization, 8% is seen if there is more than 5 disc diopters of non-perfusion. So these are few images. Here is this is a fundus photograph, and here this is an OCT image showing cystoid changes, macular edema. The investigations which we have to look for in systemic is blood pressure. Mostly the blood pressure is elevated in such patients. ESR rate, RBS may or may not be increased. We have to do a lipid profile also, and the other tests which we have to see for end organ related tests such as urea, creatinine, and thyroid function tests. We should also do a echocardiography. Chest x-ray we have to do. Plasma homocysteine level, it's seen raised in most of the cases, and all these carotid duplex imaging should also be done to exclude any ocular ischemic syndrome. Diagnosis is mainly clinical, and we do OCT to quantify macular edema for regular follow-ups. Fluorescent angiography will show venous filling defects, blocked fluorescence, and capillary hyperperfusion. These are the few pictures. These are taken from Kansky, not my own pictures. So you can see blocked fluorescence, and here collaterals and neovascularization. OCT angiography will show the loss of vascular blood flow and retinal microvascular telangiectasias. OCT-A cannot differentiate between collateral and neovascularization. Management, what we do is, if there is macular edema, we inject anti-VEGFs, and once the hemorrhages have resolved, we do sector laser photocoagulation. So these are the few studies. This is the picture depicting the scatter laser photocoagulation. The size is, spot size is taken between 200 to 500 microns, and one burn apart. Anti-VEGFs, the other VEGFs which we use are bevacizumab, ranibizumab, and aflibercept has also come. So even we are using, for non-affording patients, we can use triamcinolone and Ozurdex. Thank you.
I think BRVO mainly, like, we want to rule out any systemic cause,
Yes, sir.
and especially so if it is not vision threatening.
CRV?
Sorry?
CRV? But sir,
Yeah,
whatever
but
we
like,
have seen in BRV,
what I try to do is, we try to, whether it is kind of any vasculitic lesion, cause, or any like blood pressure or hyperlipidemia cause. Plasma electrophoresis and all, I don't know if many people are doing. Are you doing, sir? Sir, will you be required? And the other thing is, we just keep counseling them to keep a regular follow-up, and same is for pachychoroid, but in India that is an issue. People don't follow regularly. I usually tend to say that this is kind of a precursor to a hemiparesis or kind of a stroke which you might have sometime. So you should take care of your systemic illness if we are able to find some. Sometimes even a carotid bulb plaque we are able to pick up. But those are only few things if we are able to pick up. That's all. And scatter laser we are not doing as a routine, only in case
Hemorrhages, like
No,
if they have
not-
vitreous hemorrhage and
No, vitreous hemorrhage of course will occur only if there is a neovascularization. And if there is any evidence of neovascularization, especially so in the sector, then only we do panretinal or sector laser photocoagulation. CRVO, of course, we treat more aggressively compared to a BRVO. I think sir would agree
I
with
think,
me.
yes, I think what we should be doing is, at least we have followed. If you look at the large studies, and we have also seen that 90% of the branch retinal vein occlusion is because of hypertension.
yes,
If you have established that, don't go into that many investigation. We believe that. And as already mentioned by Dinesh, you see, you have to tell them there is a stroke in the retina. It's a stroke. So if you tell them, they take very seriously. You tell them this stroke could have happened in the brain or in the heart. So then they are very serious. Then they won't neglect. So I think it is a stroke, basically. So it is exactly akin to that. So I think that's how the better counseling prevails over a period of time. We learned by our own experiences. And of course, the treatment we know, you mentioned these days, anti-VEGF remains the main, and we should counsel them well. They may be lucky, especially BRVO require much less, number of
doses.
injection as compared to CRVO, we all know that. But then still, there are maybe around 30 to 40%.
Resolve on
They
its
may
own.
need long term, over a period of time also that happens. But if they fall in that other group, then after some time they may not need it. So I think that is what.
They sometimes land up with other eye BRVO.
yes, sir.
Yeah. Absolutely. If you don't find hypertension, I would say, because then we need to investigate accordingly. But not all investigation, what has been mentioned, of course, they are important, they cause it, but not that every investigation, what is happening these days, we put battery of investigations. So that's not the way to. Yes, yes.
COVID, of course, at that time it increased the incidence. Even some people reported, I think, post COVID vaccination.
Yeah.
So, but now it's going down a little bit compared to what we had, because the number of cases were more. So also the complications.
Homocysteine is raised.
I think you be careful about this homocysteine business. Once it is done in the population, majority of the people have this. So it's not a lonely factor which is causing this. That's where we are going wrong. So I think they are being treated left and right. We see all the time. And the problem is, if you look at and do homocysteine for many people, they will have high. So alone, it's not really something which should be considered that seriously. It might have contributed some way, but not. Then you need to consider in young patient other things they may have, which might be more serious than a homocysteine. That is what my take on that is. Thank you.
Thank
I think
you,
we
sir.
proceed further.
Thank you,
Thanks. Very nice. We are not going according to the chronology, so I don't know whom to call.
Is Shilpi here?
Shilpi not there.
Yeah, Shilpi not there. Amit?
Shilpi is there.
Yeah. So you want to speak, or you are ready with the presentation?
Your talk is ready? Okay, next. Then we'll take next. Yeah. Okay.
Very good evening to all. So I'll be talking on anti-VEGF agents, new agents in the armamentarium. So anti-VEGFs, you know, are the mainstay of treatment for neovascular AMD, diabetic macular edema, and retinal vein occlusion. Most of the anti-VEGFs require intensive treatment to dry the macula and to achieve optimal treatment outcomes. However, patients often experience a high medical and financial burden due to the injection cost as well as multiple comorbidities, and that this can lead to high rates of non-compliance, under treatment, and in turn lower visual gains in the long run. So this is one study which has shown the diabetic macular edema treatment in India we know although 5 to 7 injections are needed in year 1 for best results, the DME treatment in India is often found to be suboptimal. Only about a third of the treated DME patients completed 1 year follow-up, and more than only around 80% received 3 or less intravitreal injections during 1 year period. So although around 5 to 7 injections are required in the year 1, mean injections per eye in this study was found only to be 2.1, so which is grossly under treatment. So the anti-VEGFs, we know the commonly used, which has been used for the last 2 decades, are ranibizumab, bevacizumab, and then aflibercept came. And what are the newer agents? So the newer agents, innovations in the field, offer better treatment efficacy as well as longer interval between treatments. So we'll be looking at 2 agents mainly, the brolucizumab. So it was FDA approved in July 2019 for neovascular AMD, and in 2022, June 2022 for diabetic macular edema. So what are the advantages of brolucizumab is it has more VEGF binding ability per volume, and also it delivers more molecules than aflibercept in the same volume, almost 12 times more than aflibercept. So these are the 2 landmark trials, Hawk and Area trials, where they have compared brolucizumab with aflibercept. So we will be seeing briefly the outcomes of the study. You could see here the brolucizumab was non-inferior to aflibercept for the mean change in VCAA at week 48, which was the primary endpoint, and this was maintained till week 96 in both the studies. And also proportion of patients who gained more than 15 letters from baseline or who had a BCVA of more than 84 letters at week 48 or more in the brolucizumab group. Coming to the anatomical outcomes, what was interesting, this brolucizumab new molecule helps in gaining superior reduction in central subfoveal thickness, and this was maintained till 96 weeks in both the studies. And also the subretinal or the interretinal fluid reduction, if you can see here, it was more in the brolucizumab group compared to the aflibercept groups. Also the sub-RPE fluid, which is most of the anti-VEGFs don't address the sub-RPE fluid. Brolucizumab is one agent which helps to reduce the sub-RPE fluid also, even in the real world examples we have seen. And almost another advantage is the 6 milligram dose of brolucizumab helps to maintain every 12-week dosing, and after the initial loading phase. So this is another advantage. We can phase out the injections after the initial loading phase every 3 to 4 months. So these are the other studies for brolucizumab in DME, Kestrel, and the KITE studies. Again, we could see similar results similar to the neovascular AMD. Brolucizumab was non-inferior to aflibercept. So these are the visual outcomes which are similar to aflibercept, and also the proportion of patients who gained more than 15 letters were better in the brolucizumab group. So these are some patients which we had treated. You can see the RPE fluid, sub-RPE fluid, after 2 injections it has almost resolved along with the subretinal fluid. Again, in a CNBM, after 1 or 2 injections, we could see the intraretinal fluid and subretinal fluid has completely disappeared. So one issue with brolucizumab is the ocular safety profile. So these patients with systemic ocular vasculitis or uveitis, these patients can develop vasculitis or vascular occlusion. So this we should be careful in these patients. So next agent is Vabysmo or faricimab. It is the only agent which is acts via 2 distinct pathways. It is known as a bispecific monoclonal antibody. It also blocks angiopoietin 2 in addition to vascular endothelial growth factor 1. So these are the trials for faricimab. Again, we could see here 4 monthly dosing was maintained in almost 50% of the patients in all these studies, which we have shown for both diabetic macular edema and neovascular AMD. So this is another advantage of this newer drug. So this is again a real world evidence of patients initially non-responsive to aflibercept. They have responded well to faricimab, and the vision was maintained at the end of 2 years. So another newer modality of injection is the pre-filled syringe, which has come. The Eccentrix has come with a pre-filled syringe, and even the ranibizumab biosimilar Rezumab is coming up with a pre-filled syringe. So what is the advantage of the pre-filled syringes? It reduces the injection time and loading related risk of endophthalmitis, and sometimes some air bubbles can go inside the vitreous cavity. So that is reduced. So again, we have the biosimilars, you know. So these are the biosimilars which are currently available in the market. These are also many of them in the last 3-4 years they have been launched, and even aflibercept biosimilars are now available in the market. Even the biosimilars show good results, especially in diabetic macular edema. Even in CNBM, if the patients are not able to afford the brolucizumab or aflibercept, we have gone ahead with the biosimilars. They have shown good response. So to summarize, the newer agents offer long drug durability. Injection intervals can be phased out to every 3 to 4 months. And the brolucizumab, we should be careful in patients with active uveitis. So young patients, again with CNVM, we should look for any evidence of uveitis and try to avoid brolucizumab. And the sub-RP fluid that currently is being addressed by brolucizumab very well. Thank you.
Thank you for nice presentation. I think anti-VEGF is like such a huge area, and all of us and everybody, in fact, we are blessed in Retina, and that something like that came in and made so much of difference to the patient and to us. I think what you said already, the problem with the newer ones, especially when we go back to the ones which are available, and you already talked about diabetic and the under treatment, the real world experience. You see, what we have seen, and we were not able to do that earlier, diabetic patients are different. Some of these diabetic macular edema patients, once we undertreat them, you are treating them forever. So once patient, we had biosimilar, even like Irasumab, or when Eylea became under a scheme, in some of these patients, at least we have followed the protocol, given 5 injections of Eylea all the way, and subsequently you find that they need very little injection, maybe once in 3 or 4 months, and some of them, they were free of injections. So I think that you should keep in mind. What is happening with Paginex at this time? We are not able to give loading dose, we fear that, vasculitis. So we are treating forever. So what is happening is that we let it come back and then we give another injection. So there is no end point. That is where there's a lot of things are happening the way we are treating in this country, because it is a very good drug, very effective, dries out everything, but then because of that fear, we are only using PRN. So that doesn't get really in the long run a benefit. So whatever trials have been done, even if you use 6 injections in diabetic macular edema of something like Razumab or any of these biosimilars, you will find similar results. And that is where you reduce the number of injections, and ultimately by 3rd year, you may have just 1 or 2, 3 injections. You will get rid of that, but not otherwise. That is what I'm saying. Yeah, well, that will be subsequently, but the question is, how do you treat them optimally, give them the best, as well as in the subsequent year, you're going to reduce their burden, and much less injection and visits will be there.
So according to the concept and what you're saying, so just one thing. So supposing a patient is there who has 20/60 vision with DME, we give 2 injections as per the loading dose protocol, and by the third visit, his fluid is dried up, his vision is 20/20. Now, Dr. Neil Bresner and DRCS say you should give 6 injections, as you are saying, so should we stop there, or should we still give further injections if the DME is dried up?
Actually, that's where the problem is. DME sometimes dries up with first injection, and we stop, and we want then that to come back, and that becomes PRN right from beginning. So that is where our problem is. So we have to somehow believe these trials, and that's how they have said that how you reduce, especially in DME. It is a different ball game altogether. So that's what I was mentioning. That is where we are. Because once it is dry and we want it to come back, it becomes PRN. So then it doesn't work. Yeah.
Even I think that gap or the void is still there. Even I think aflibercept is coming up with a higher dose.
Yeah.
They are coming up with 4 times the normal dose, and that also may be available very soon. So ultimate aim is, as you said, to reduce the number of injections over a period of time, and the cost. So I don't know.
Yes.
The end point we still don't know.
Yeah, I think in diabetic you can achieve end point. In AMD it is different ball game.
Yes.
Perhaps very difficult to achieve, very few. There you may have to consult patient differently. They might require sometime lifetime injections. There the natural disease also catch up. So that is different. So we are dealing with all different kind of things. Thank you very much.
Dr. Shilpi, how to manage incomplete PRP?
Good evening, everyone. So this is a very basic talk for postgraduates. So what is ideal PRP? we all know that how the laser is to be done. If we take the area, nasally it should be done up to 500 microns. Temporally it should be 3000 microns away from the disc. Superior and inferior you should do up to the temporal arcades. Distance is approximately 1 burn width apart. The main important thing to learn is that we should always laser the inferior retina first, because many a times after doing the laser there are chances of vitreous hemorrhage. So if you do the inferior retina first, then you are able to complete the PRP in one sitting only. So what are the reasons for incomplete PRP? The most common reason is a beginner. Yes, they are very known, and the media haze. So beginners, yes, because of the vitreous hemorrhage, or even if there is no media haze, then there are more chances that there will be skip areas while doing the PRP. The type of the laser you are using. There are mainly two types of lasers which are being used, green laser and the red laser. So it is known that the green laser has a poor penetration, especially in cases when there is a media haze in form of nuclear sclerosis or vitreous hemorrhage. And in such cases, red laser is always preferred. Laser delivery system also is one of the factor. If you are using 3-mirror gonioscopy lens on the slit lamp system, then there are more chances of skip areas which occurs in the areas between the different mirrors. So in such cases, you can use the panfundoscopic lenses or the Menster wide field lenses, in which in a single mirror you can cover the full retina. LIO delivery system is preferred in cases of media haze, but the main disadvantage is it has a long learning curve. Now, how to tackle the media hazes? So these are the various situations which you can get along with the various, in cases of PDR or any other thing when there is media haze. So in cases of corneal edema, you can manage it with the hypertonic solutions. You can use epithelial scraping or the anti-glaucoma medications, or even the surgery, and you have to reduce the corneal edema first, and then you can go for the lasers. In cases of small pupil, you can use 28 diopter lens instead of 20 diopter lens. You can atropinize the eye, or you can also take the laser pupilloplasty, so that you can increase the size of the pupil and you can do the lasers. So in cases of cataract, LIO delivery system is preferred. Red lasers are preferred, and if you use the more energy, you can do the pan-retinal photocoagulation. But if you feel like that the media haze is significant and none of the methods are able to, you can complete the PRP, then we should first go for the surgery and then do the pan-retinal photocoagulation. In cases of vitreous hemorrhage, yes, I already told, always do the inferior retina first. Always titrate the energy according to the amount of the vitreous hemorrhage and also the area you are doing. And in such cases also, the preferred laser is the red laser. So this is a case which was presented at the presentation. After 2 weeks, there was reduction in the vitreous hemorrhage with just conservative management, and then the stepwise laser was done. As the vitreous hemorrhage was clearing, the areas were lasered. Another thing is the anti-VEGFs in the vitreous hemorrhage. So there are 2 studies, protocol S and the Clarity, but the main prerequisite for giving anti-VEGF in vitreous hemorrhage is that there should be no traction. So which should be confirmed on B scan. So this was a case of vitreous hemorrhage, B scan was done, there was no obvious traction, so the anti-VEGF was given. So after 1 week of anti-VEGF, this was the picture. Then 2 weeks later, there was further reduction in the vitreous hemorrhage, and in such case, then the laser was done. Choroidals happens with the number of spots you are using. It happens more commonly with the eyes with the shorter axial length, and if you treat more area in single sitting. In such cases, just defer the laser till the choroidal subsides, and you can also use topical steroids and mydriatics for the earlier resolution of the choroidals. In cases of PDR with traction retinal detachment, always do the laser 1 to 2 diopters away from the traction. Your goal should be the regression of the vessels, but if you still feel that the disease is progressing, you should always go for the surgery. In cases of neovascular glaucoma, first reduce the pressure and the media haze by the use of steroids, anti-glaucoma medications. Anti-VEGFs, we still don't know whether they help or not, or we should adopt this method or not. In case by any of the method it is not possible to complete the laser, or the disease is progressing, or the neovascular glaucoma is uncontrolled, we should always opt for the vitrectomy in such cases. So this was the case. Laser was done. There was, in the superior temporal arcade, there was minimal traction, but non-resolving vitreous hemorrhage. So after doing the vitrectomy, you can complete the laser on table also. Now, when to do the laser up to ora serrata? In cases when you need to do the fill-in lasers, if there is significant skip area, you should do the lasers immediately. But if you feel that the laser was done adequately, but the disease didn't regress, then after 3 to 4 months of the initial PRP, you have to do the fill-in laser. In cases of aggressive diseases, when there is multiple NVEs, then you should always opt for aggressive laser up to the ora serrata. In cases of neovascular glaucoma, post-vitrectomy also, many a times when there are no iatrogenic breaks, the fluid persists, which automatically get resolved after a period of time. So after removing the membranes, you should not always opt for doing the laser, as the laser per se you can cause the iatrogenic breaks. So in such cases, let the fluid get absorbed and then you complete the laser. So these are the two cases which are being presented here. So to conclude, always go step by step in case of difficult situations. Tighter the laser energy depending upon the situation. Anti-VEGF should be used judiciously, and in case of progressive disease, don't wait. Surgical management is the option. Thank you.
Thank you, Dr. Shilpi. I think this is very important, how to do laser and how we should proceed. What my questions to you is, in present time, in case you have a high risk PDR, you don't have proliferation of what you call corrections or other things. So do you give anti-VEGF before you start PRP?
Sir, if media is clear, we don't give anti-VEGF.
So you see why I asked this question. I think this trend is catching up. In such cases, if you do that, I think you have a more safety profile, as well as you can do much more laser everywhere, wherever you want. Because, and then in such cases, we have seen in past that they do bleed at times when you are doing laser in these cases. So I think in that cases, those cases, maybe if we can use even if you don't have anything, you use Avastin, which works very well, which is the best in fact for new vessels. So, and then you do PRP, they may do much better. Of course, you can use biosimilars or whatever, any other, because if in case there is a fear of having infections and other issues. And second thing, what you said is about the type of lasers. I think red laser is hardly used. I don't
Yes.
take from the studies done by us, especially on ROP. You see, first laser for ROP, we got with great difficulty way back in 1997. And once that laser conked off, I didn't know what to do. So I started using 532, and which was contraindicated. And since we had substantial cases, we presented in American Academy. They took in writing from me to present that poster, because they said we are doing something which is not done. So I gave in writing. I was confident we had good, and I knew they'll not publish that. They didn't publish in ophthalmology. It was published in British Journal. But what I'm saying is why I brought it. That changed the whole practice. You use 532 laser for ROP. So same laser can be used for everything. So I'm talking from economics point of view also. So I think it works very well with vitreous hemorrhage as well as pre-retinal hemorrhage and little cataract and other things. And since we have anti-VEGF these days, so we can always tide over that. And if we tide over that, as you said yourself, even the cataract surgery can be done because you have anti-VEGF, and then you can subsequently even laser early with LIO rather than putting in a lens sometime, which may not be good.
Yes.
I have only one laser, 532, for last 18 years, and I do everything with that.
I think most.
We
ROP,
do only with the
endolaser,
green laser, sir,
slit
but
lamps.
it is just
Yes.
those who have the facilities of
Yeah,
suppose both the lasers.
Actually, that is what you are right, because this targeted photocoagulation concept which came up with that, and also with wide field angiography. It's not only that, so because wide field is available, as well as those kind of lasers were available where you could do that. But you see, the question is whether how much practical, how many people have wide field angiography. Once you don't have that, you won't be able to find out that area. So I think if we stick to a good pan-retinal photocoagulation, which is traditional, I think that is way we should go at this time. Down the line, once we have more of these machines available, because that wide field would be required. You won't be able to get otherwise selective area to do that. So I think at this time it is too premature. That's how this targeted thing has not really caught up that much, even in the Western world.
One point, ma'am, according to the context of the presentation, incomplete PRP. So what, in my short experience also, what I've learned is that even with a wide field lens, your PRP is not complete. Because there's still a disc or 2 disc diameter area that the wide field lens cannot reach up to the aura. That because the ultra wide field angiography and all these modalities have showed us that that peripheral CNP area is still left, and that can be a cause of a DME or even recurrence or hemorrhaging. So maybe addition, what I normally do is I add also with an LIO and with all clock hours examination, so that examines as well as I'm able to laser that area as well.
So usually what we do is, in a primary setting, we never do up to the ora serrata. If it is a non-resolving case, then only we do up to the ora serrata.
So what I normally do is I just do a slit lamp 3 sittings standard PRP, and especially for patients who are young and who have PDR, I just do as anterior as possible and leave the area up to even up to the equator, so that their field is not that much lost. So I just complete about 3000 spots, and then after that I think we just need to titrate with the disease, whether the disease is progressing or not. So if you still have neovascularizations, then you need to keep adding, and wherever, maybe anteriorly or even posteriorly. So sometimes we need to do 5, 6, 7 sittings also in these patients. I hope Dr. Dokha will agree with me, sir, because I am not doing like anti-VEGFs for PRP, because that's also one concept which has been there in Western world, that to keep doing anti-VEGFs for PDR. So, but in India, I'm not a votary for kind of anti-VEGF injections for PDR. Of course, it is there for DME.
Yeah, I think those repeated injections are different. What, in fact, don't look at the new vessels. They may stay there forever and never bleed. You see, these are now the mature vessels you have found out, so don't chase them. So for that sake, don't keep on doing repeated PRP until unless they start leaking. Patient is complaining of those black-like spots coming, or you see some small hemorrhage. Otherwise, you will keep on treating the whole retina, and it will become tubular, and you will become, don't do that. So the PRP doesn't mean that we have to do excess. PRP means you have to do enough. So from my point of view, it's never like what Dinesh mentioned, 3000. It can vary anywhere from 1200, 1400 to even what he mentioned, 3000. Because it is going to be variable for every patient. It's not going to be one shoe fitting everything. So that is the way we proceed. Thank you very much.
Thank you.
1500 in 1 or 2 sittings? Or
Yes, 2 to 3 sittings again. Yes.
No, 3000 also, I'm saying in 3 sittings in total. Not,
what I'm saying is 3000 fixed may not be required for every patient. It might be enough, the half of that may be enough for many of the patients, those who don't have that aggressive disease. That is what. Thank you. I think we proceed on to the next talk.
Dr. Sangeeta, is it
Yes.
a game changer in DME armamentarium? Dr. Sangeeta ji.
लगा रहा है वो लैपटॉप वो चेंज करना So, good afternoon everyone, and I really thank AIOS to give me this opportunity to be over here. When we talk about, like as we were discussing about all anti-VGFs, we had a lot of injections earlier also tried, but we were not satisfying, and still we are not yet satisfied. Still we are trying to search something or the other. But when the brolucizumab came in market, I found it as a game changer, especially for my DME armamentarium. So this is my disclaimer. If we look at the UN resolution, how to fast track to the disasters, like India will spend nearly 3.3 billion to 5.3 billion by 2025 as a treatment cost for diabetes. So 40% more than what it does at present. So this is about the data of diabetes, and as we all know, every one of us might be having one or the other diabetic patient in our family. So out of these diabetics, if we look at the number of diabetic retinopathy patients, they are coming, nearly 5,000 new cases of blindness per year we are getting reported. And this is how the flow of PDR, severe NPDR and moderate NPDR and mild NPDR is coming up. Are you changing the slide there? So if we talk about the burden of DME therapy on healthcare systems, it's multifactorial. Like DME burden is for declining vision, burden is increasing to declining vision, treatment choices, monitoring needs and treatment regimens. As sir has already said, we have to think of every patient and then think of which drug to be given and how many times to be given. So the treatment burden can lead to adherence and persistence problems also, as we all know. So I would like to come to my cases, what I have gone through in my practice. Till date, I have done nearly 475 cases in 2 years, 2.2 years and 2 months. So this is 68-year male. Can you go to the back, please? 68-year male, diabetic, hypertensive, with mild deranged KFTs, while right eye is 4/60 and left eye is only 3/60, and already had 13 anti-VGFs and IVT earlier elsewhere. Next, please. So the patient, when presented after these many injections, had this kind of OCT and, this kind of OCT with 4/60 vision, and at this point I changed the drug to Paginex. After 3 months he improved to only 660. Still the fluid is there, but the distance between 2 injections was increased, that it's not every month, it's not every 28 days. It's like 3 months we required, and this is a new patient, so I don't have much of a follow-up of this patient right now, yet to come. 38 years male, a very interesting case, judged by profession for the civil court. Diabetic last 5 years, had left eye diminution of vision since 15 days to 6/60 and right eye 6/36. Already had 17 anti-VEGFs in last 2 years with me only, with multiple combinations, permutations, whatever I can do. And at the end, in June 22, we came up with Paginex. So this is my follow-up, how he gone with June 22, then July 22. At first we gave at June, July we just did a follow-up and continued with Nepafenec kind of a drug. And the next injection what I required is in January 23. So my first injection of Paginex, if it is working for 6 months, I will say yes, it's working much better than other drugs, so as to increase the duration in between the injections. And definitely being a judge, if he is maintaining a good vision, even for professional needs, he is doing well. After January 23, again he reported to us in May 23 for left eye macular edema or left eye diminution of vision, where we required the second injection. And then in August 23, if you look at the gap, at this point we required like 2 months, 3 months gap, while it was for 6 months earlier. And in after August, sorry, I'm not able to see. After August, even in October 23, the patient was doing well. And after the October 23, the patient came to us in June 24. Look at the gap in between 2 visits. So the patient is requiring very less injections with a better quality of vision and maintenance of vision, which is much more required for his profession. 35 years female, as we were discussing about the long-acting drug as the Pagenex is, this case taught us the PRN protocol. Type 1 diabetic with deranging KFT and CRF, only 2/60 was the vision, and she was a treatment naive patient. So if you look at the pre-op OCTs and Octa images, first injection gave, and after post 3 months, she improved from 2/60 to 624, and she remained to 624 post 6 months, even after single injection. But if you look at the OCT, there is a retinal thinning also, macular thinning also. So as sir correctly mentioned, we have to look into, as it is a long-acting drug, okay, it definitely increases the duration between the injections, but as it is a long-acting, you might have foveal thinning at times, so you need to have a close follow-up of your patients. So this was an 52 years female, diabetic 15 years, TRD in one eye where we haven't treated, left eye DME, already lasered retina 3/60, post 18 anti-VEGFs. If you look at this series of OCTs 3/60, 5/60 and only 636, this is 6 months follow-up, but we required only 2 injections, though the fluid is still there. We are still waiting, we haven't injected the 3rd injection because at times there is a study which says fluid at times works for better vision in few of the patients, so we need to calibrate as per the patient needs. 60 years female, male, lasered retina, no uveitis, glaucoma, already had 7 anti-VEGFs, and this was our, from September 2021, April 2022, and this is the last follow-up what we are going to June 24. So in last 2 years, 2 months, we required only 5 injections. So if we are reducing the burden per injection to the patient, we are definitely giving him better vision with low financial burdens also. So adherence to follow-up and treatment, it increases with this kind of treatment. 75% patients receive incomplete treatment because of non-adherence. So as to conclude, definitely brolucizumab resulted highly effective in restoring the anatomy of eyes affected by DME, in stabilizing the visual acuity of both treatment naive and even refractory cases with other anti-VEGFs.
Thank you, Dr. Sangeeta, for bringing out what we can achieve with newer drugs. I think, as you said already, of course, we don't have that kind of a protocol here where what we talked about loading doses. But I was even trying to talk to many people that even if suppose some people are giving every 2 months, so if we can give in the beginning, say every 2 months and then extend it, I think it may work better. But I do have my own patients, those who were refractory for multiple treatments, even including Ozurdex. They have worked and they are on Pagenex and they are doing very well. So DME is different from, I would say, AMD as far as the use of Pagenex is concerned. Only thing is sometimes I've seen is, I think we should look for the cases, those who have uveitis in past or vitreous cells and other things. I think there we should be careful. Many a time I do write myself there, please avoid Pagenex in those situations, because we want to have a safety for ourselves. But great presentation, great cases.
But sir, like in diabetic macular edemas, we need to, like we calibrate the patients. If patient is coming for continuous follow-up and we are observing OCTs continuously, as and when required, we are going ahead because there is a multifactorial disease.
Not only that, I think fluid is tolerated much more in cases of diabetic. It is not damaging as is in cases of AMD. AMD, we don't want that to come back.
Yes.
Here it is, even if we have gap of, and they do have a gap, because they have other systemic issues, as you mentioned, many of our patients having nephropathy, renal transplant, heart issues, others. So I think we have to accept that part. So, but they will not be kind of going for worsening even if we have some gap like that.
Yes.
Thank you.
Thank you, sir. Sir,
No,
in
no, no, no,
475 cases, I haven't.
No, no, not US. Yes.
In 475 cases, I haven't gone with any IOS, so I'm like 100% confident of using
Yeah, I think
drug.
the same thing, because you have not gone for loading things, and it's not that it doesn't happen. It can sometimes just happen. We may have some vitritis, some other things, and then it gets controlled. And of course, we have not seen occlusive vasculitis, but of course, we have not gone for that kind of a loading phenomenon.
definitely we
So
are-
I think we need to generate better protocols and better thing for our own patients here.
Yep.
If we can do that and we collectively have that kind of approach, we may be able to serve much better these kind of especially patients like in DME.
Yes.
Thank you.
Thank you, sir.
Yes, yes, yes. I have done that because I have had a very bad experience with one of my Solzivdex patients. Sometimes it happens. He got so crazy, he wanted me to remove it. And he was coming every other day because he got some kind of a thing. No, no, no.
Audible, you're not audible.
Ozodex,
Sometime-
even for patients recalcitrant to Ozodex, he said Paginex.
Yes, yes, it does work in such a situation also. And sometimes it does happen in a patient. It worked very well for him. Paginex was effective, but he was not comfortable with that thing moving inside. He said, there is something in my eye, and please take it out. Although my vision is better, but I can't sleep at night. I can't. There are some patients, you see, this may be a rare phenomena, but it can happen sometimes. So I think that's what it works very well in many situations where we have challenges of that kind. Yes.
Thank you.
Patients do see that thing.
Yeah, not all the time.
Ozodex.
Yeah, not all
like
of
the
them,
patients,
yeah.
they do come up. I just usually say them that like till the time you are seeing this, it will work. After that, it will stop working.
With the new drug Vabysmo that's come out, will your practice change? Will you go for Vabysmo first and then Paginex in such cases?
Actually, you see, the question would be again boiling down to the economy part of the cost. If we go according to the protocol, the way they want us to use and what has been done, that we will be giving 4 injections monthly, and then only we can extend. So I think so all those things boil down to, but then we need to collect data. We need to know. They are harping on one more thing there, that vascular permeability goes down and their vascularity goes down because so we know that. I think it's too early for us to kind of give verdict on that side.
Yes.
Thank you.
Thank
you very much. I think we go on to the, is it the last talk? Yeah, yes, last talk by Dr. Varis. He's going to talk to us on molecular and genetic level markers for early diabetic retinopathy changes, creating new hope.
ठीक है लगा सही था ऐसे कर लो अब शुरू कर दो फर्स्ट पेज good afternoon. I am the last speaker, hope not the least. एंड कितना भी सीनियर हो जाऊं सर के सामने बोलने में अभी भी थोड़ी सी हिचकिचाहट होती है एनीवेज तो आई विल बी टॉकिंग अबाउट ए टोटली सेपरेट इशू एक्चुअली व्हाट हैज़ बीन डिस्कस अप टिल नाउ आई विल बी टॉकिंग अबाउट द मॉलिकुलर एंड जेनेटिक लेवल मार्कर्स फॉर अर्ली डायबिटिक रेटिनोपैथी चेंजेस probably creating new hopes. We all know that diabetic retinopathy has become a menace, a catastrophe of sort, with millions and crores affected worldwide, and India is definitely the world capital of it. There is a huge shortage of retina specialists, as we all know. I think yesterday I was checking, we have only 1,000 VRSI members up till now. We're probably catering to a population of crore, especially in the periphery. Or I did a research also. There I found that the rural population is having more diabetic retinopathy than the urban population because they're neglected actually. Anyways, so in our armamentarium of diagnosing and treating diabetic retinopathy, we have just now we discussed so many things. We have got all sorts of latest instruments, all sorts of latest therapies. We talked about new anti-VEGFs. Many more are going to come, but what is the need of the hour? 1,000 retina doctor gang, can we control this menace of diabetic retinopathy? Or will a country go blind? So we have to think something different from what we are already doing. So the need of the hour is to reduce the cost for diagnosis and treatment of a country like ours, where there is a lack of resources. And now we should focus on some other modifying factors at the genetic, molecular, hormonal, or lifestyle modifying things, which especially the lifestyle modifying factors. So basically, I would like to share few of my researches, and I think I will give all credit to my PGs. Many of them are sitting over here. Before that, we all know what is genomic biomarkers. Genetic biomarkers are the one which predispose individuals to a particular disease, say for this case, diabetic retinopathy, which could either lead to prevention or slow the process. And by genetic editing techniques like CRISPR technique, as this chart shows, we can catch hold of that area, and probably we can rectify the gene. A diabetic person may have diabetes but will not develop diabetic retinopathy. So some of the researches which we have done in our institute, I would like to share, and those are all on the molecular or genetic or hormonal basis. This research got the best award also last year. It showed a positive association. We did a genetic polymorphism study by GNA polymerase, and we did all sorts of this RNFLs and all. We found that minus 374 TA polymorphism is associated with diabetic retinopathy. Probably in the future, if we do by CRISPR technology a genetic engineering and remove this polymorphism, probably the incidence of diabetic retinopathy may come down. Okay. Another study showed that estrogen had a protective effect up to menopause age. After menopause age, after the age of menopause, after that age, we have to give, or we should give, estrogen dose, otherwise the incidence of diabetic retinopathy is more. Okay. Again, with thyroid also we saw that hypothyroidism is associated, because both are autoimmune diseases. So hypothyroidism is associated with more incidence of diabetic retinopathy. Therefore, in my protocol, now all cases of diabetic retinopathy I am sending for a thyroid evaluation regularly nowadays. Same with serum cortisol, we saw higher serum cortisol associated with diabetic retinopathy, and lower prolactin associated with higher incidence of diabetic retinopathy. Again, hypocalcemia was associated with diabetic retinopathy. We have to give calcium supplements. These are some of the other studies which are ongoing. These are some insulin growth factors and inflammatory marker like HRBP. This is a very interesting study about brain-derived neurotrophic factor. As we all know, BDNF is a neuroprotective agent which decreases levels in neurodegenerative disease, and diabetes is both causing neuropathy as well as vasculopathy. Okay. So BDNF level, we have seen that it is lower in cases of diabetic retinopathy. So it is causing neuropathy, and I'm afraid that probably in the near future I will be working on dementia and diabetic retinopathy, and we will find the level of BDNF. One of the work we are doing on epigenetics. Epigenetics is basically disease modifying. We don't change the genes, but factors which change the genes quality basically. So we are working on DNA methylation study, which is affecting the mitochondrial dysfunction. Another study, these are inflammatory markers. One is transforming growth factor beta 1, and another is ICAM. Both these are ongoing studies. Probably in the near future, we'll rely more on deep learning, artificial intelligence, and probably deep learning can tell us, we can have a fundus photograph of a DR patient, and it will tell that after 5 years or 10 years, you will have this stage of diabetic retinopathy. Modify it, otherwise you are going to get blind. We all know the role of telemedicine and wearable technology for monitoring, which can basically 24 hours can give you a feedback of your blood sugar level or something like that. Latest anti-VEGF, nanotechnology based or sustained release implants, stem cell therapy, which can reverse the effect of diabetic retinopathy, probably. These are latest stem cell therapies, and it does work in early and moderate, but not in the advanced stage. Nowadays, stress is that diabetic retinopathy, one of the main causes mitochondrial dysfunction. So either we treat the mitochondrial health by giving antioxidant therapy or some antimitochondrial energy giving things, probably. Another very interesting thing I saw was the role of microbiome and so the gut and retina relation. Something. It showed that there are some probiotics and prebiotics, and they are associated with higher incidence of diabetic retinopathy. So probably if we have a good healthy GIT, with good diet and good healthy lifestyle, probably it also affects diabetic retinopathy. It's a research or thought to in the near future to work on. Okay. And last but not the least, I always stress, change your daily behavior, reduce your stress, change your diets, do yoga, do adjuvant therapy, be stress free, and that has a lot of bearing on your diabetic retinopathy also. The future of diabetic retinopathy treatment lies not only in the cutting edge technology, but in our commitment to early intervention, patient education, and collaborative care. Together, we can protect vision and enhance life. Thank you.
Thank you, Dr. Varis. I think great concept. We need to work more on these things to find the genetic biomarker and target them at an early stage, and we should have so many things coming up which might help us to tackle this kind of a problem, which we in fact are treating all the complications, and if we tackle it before those things happen, that will be great. So I think your presentation is very well taken on that behalf.
Just a basic thing I just wanted. So are these biomarkers and genetic markers, are these for diabetic retinopathy or for diabetes? So these are basic. No, like what we are trying to do, are we going to treat diabetes, or these are biomarkers for diabetic retinopathy in cases of diabetes? No, what I'm trying to say you is, like, if we are able to find some biomarker or a genetic marker for diabetes, then might be that we are going to treat diabetes as such. Yeah, then even nephropathy and neuropathy and other things, all those things can be taken care of. So that's what I was just wondering. No, because we do see a lot of variations in diabetic retinopathy. Some people get very florid diabetic retinopathy at a very early stage, and some people don't get it even till long, even till 30 years. And with good control or without good control, I think some families, they will get very soon, and some may not get it. So I'm sure there is something else going on in addition to hyperglycemia. But what I am trying to just ask you is, if these biomarkers can be for diabetes, then maybe we are treating the disease itself. Because as of now, we are treating the effects of the disease. Thanks. Thank you.
So if there are no other comments or questions, we'll close the session. I think we had a very good session and a lot of discussion. Thank you very much for everybody staying so late here.
Thank you, sir, for all the guidance.